learn how to do an alternative method of patient interviews.
Super. That's great. Anybody else? It doesn't have to all be glowing. I mean, tell the truth.
I guess something that I thought was really cool was just being able to work with another discipline, because I'm a first year, so I have not had an experience of working with any other discipline. So it's like, it was really, really cool being able to work with nursing students and kind of get that vibe. And I just thought that was really, really cool. Just, it's a really great experience.
Super. Someday we'll hope you'll have you, together physically in the same space, doing the same or similar things.
Just in kind of a sort of similar but kind of different way. My job before I started med school was working at a psych hospital, and I was a pediatric behavioral health aide. So I was kind of at the very bottom of like what you're allowed to do as far as patient interactions go. So it was very interesting trying to work with a different patient population in psych than I've had any experience with, and be working in a completely different environment where the amount of control and the amount of direct access you can have to a patient was way different than what I've experienced before.
Thank you. Let's talk a little bit about the two cases. Some of you had one case and some of you had another. So who wants to tell me about the case with trauma? Just tell me about the patient's story. Boy, it's going to be a long night.
So her name was Taylor West, and she presented with inability to sleep and concentrate at work, and she also has nightmares every night of the week. And when you asked her further about when this started, it started a week ago. And a week ago, she was in a car accident, and she said that it was all her fault, and she feels really guilty about that and a lot of shame around that fact. And because of that, she has not been able to drive and feels a persistent anxiety around driving and when she thinks about driving. And so she has had her coworker and her husband take her everywhere and to work. She hasn't been able to concentrate at work either. But then the second really big thing in her life right now is her sister passed away of COVID 3 months ago, and she was not able to, they had a funeral, but she wasn't able to be with her when her sister passed away. And so there's been a real lack of closure for her. And between those two traumatic events, she just has had a lot of difficulty and it's really affected her day-to-day life and her sleep, especially her sleep too, making her exhausted all the time.
Okay, thanks. How about from nursing? Anything to add to that case?
Yeah, so Abby summarized it really well. She had tried using different medications for sleep, none of which worked. And then she also had, at least our patient said that she had had some thoughts of dying, but no suicidal ideation as far as a plan and self-harm goes. Also, shout out to Casey, my medical student who I worked with, because she did a wonderful job asking all these questions I didn't even think about. So shout out to Casey.
Yay, Casey. How comfortable were you all with asking those kinds of questions? For those of you who had that case, how many of you asked frankly or explicitly if she's thought of harming herself, if she has a plan, if she's thought about killing herself? Mackenzie did? You want to tell about it?
Our patient actually said she didn't have any thoughts of harming herself, but I did ask. I work as a tech in a hospital, and so a lot of times I'm in float pool, so I end up sitting in, and so we actually do telehealth at my hospital for the behavioral screen, just like the screenings. And so I had a lot of patients with trauma, they'll ask that question. So I was like, I'm just used to hearing it asked. So it actually wasn't that difficult for me just because I'm so used to being in on those conversations. But ours didn't say, I didn't get to assess anymore because she basically just said, no. So I was like, didn't ask if she had any like objects in her home or if she had any plans or anything like that.
So I think the message there, though, is that it takes practice, right? So the first time you ask those kinds of questions, and we'll talk about the other case in a minute, but the first time you ask those kinds of questions, they feel really weird and like maybe you're provoking something. And I know you in your training, you were told that that won't cause people to act out, but you still have that like, gosh, I don't want to offend them. But with time and doing it over and over, you realize that you have to do that and you have to get that information, and it's really crucial, right? Any other experiences with that aspect of the case, about talking with her about her extreme sadness and depression?
I think for me, I just wanted to make sure that she had a good support unit, and from what she gave us feedback, it really didn't sound like she could talk to a lot of friends, especially during these times. So that was like the thing, was to make sure she got some counseling and someone to talk to.
Okay. Yema?
I was just gonna say, I've never had to do this over like Zoom, so it felt a bit uncomfortable when like our patient was like showing emotion. Like I wanted to be there with them, and that was a little hard to navigate that. Like I could just express it with words, I guess, but I don't know if that is the same as being, you know, face to face with someone during something like that.
Right. Yeah, in both of your all's professions, nursing and osteopathic medicine, you're both used to being able to touch patients, right? And that lack of ability to reach out, even if it's just putting your hand on someone's hand, really makes you realize how much, you know, you really want that. You want to be able to do that. So you have to use your empathetic words and, you know, all of the active listening techniques, etc. But it's hard, you know. Somebody else was going to speak, and I don't know who it was. And now they don't want to anymore.
I just add that as a therapist in March, it was really, really hard to switch to Zoom counseling. It was really hard for that very reason. And it still has difficult moments because it is, I'm used to my patients with me. I'm used to reading body language. So as the months have gone on, it's become more comfortable, what I'm more used to, but I still prefer face-to-face, and I can't wait to see people in person.
Yeah. Let's talk a little bit about the other case. So who wants to tell about the other case that some of you had?
I can.
Logan?
Oh, okay. Okay. So we had, or at least my patient was Andy Smithson. She was a 52-year-old female. She came in today seeking help for excessive drinking. She hasn't previously sought out help at all. And it started about 2 months ago with the frequency and the amount of alcohol increasing as time went on. I found out that, me and the nurse there found out it was 8 to 10 drinks per day of vodka and tonic water, bringing it to work and to other social events like I believe it was her grandchildren or her children's like soccer games and things like that. And she like has fear and embarrassment both from her family and from her job. She did have like withdrawal symptoms and cravings, loss of sleep, increased anxiety. And she thought that this was mainly due because of the COVID pandemic and her job as a professor. I think that was about it as far as what I remember.
Okay, anyone else?
I just wanted to add, it seemed like this was really brought on by anxiety due to the pandemic. My patient, same patient, obviously, same case, but he reported a background of 6 to 7 months starting with the start of the pandemic and it growing from there. So that's, I mean, it's just something I included in my SOAP note. Like you can address the alcoholism, but also address the anxiety that's coming beneath that.
Yeah, great, great.
Yeah, and then to add, the CAGE assessment that we had to conduct, I think helped her to communicate different aspects of her own concerns with her self-identified alcoholism, but also how she's had a lack of support, or in our case, like her husband was supportive, but she lost all of her coworkers as friends and she can't see her students. So it's kind of helpful to really see, you know, the full picture and then to educate her on the problem that she brought forward, but then to say that it's good that she came in for intervention.
Good. How comfortable did you feel with asking those CAGE questions?
So similar to Mackenzie, I worked as a tech in a hospital. And so like as a side note, we had to ask a suicide question in like a 5 stanza setup, which is always really awkward. So similarly, I was kind of used to asking kind of straightforward questions. I tried to give a little segue into it saying why we're doing it, especially with, I knew 2 of the questions she would automatically say yes to because she had already said those things, but I made it very clear that we're trying to get a full picture. And that way giving her an opportunity to talk about things. So then she was actually able to expand on her previous comments. So it actually went pretty well, I thought.
Okay. Anybody struggle with asking those CAGE questions or feel uncomfortable or like it was awkward? No. Okay. We talked a little bit about the empathetic response and how it's a little bit harder in this way, but how do you feel like you were able to express empathy with either of these 2 patients? What techniques did you use?
Verbal affirmation and then allowing them time to verbalize their grief, recognizing it and letting them verbalize it.
Okay.
I tried to say that their feelings were valid and normal based on the situation. Mine had a different case, but
good. Good.
I did thank her for coming in, saying that, you know, it's hard to kind of do that. So just that's really awesome that she felt comfortable with coming in and talking about this, as it's not an easy thing to talk about. So just making sure that she felt like we were happy that she wanted to talk about it.
Good.
Yeah, I also thanked our patient, and when talking about like a treatment plan, doing therapy, I asked her if she was okay with that and how she felt about that, and she seemed to be happy that I asked her.
Mm-hmm.
My patient was, sorry, Logan, go ahead.
Go ahead, Rachel.
Okay, but one thing my patient said was I made sure to assure them that it was all confidential, and he seemed really grateful that he was like, yeah, I don't want this to get out. I'm really embarrassed about it.
Yeah. Good.
Yeah, and I was just gonna say, as far as like the treatment goes, you know, I kept telling the patient, you know, the first step was, you know, you coming here, and that's like a really hard thing to do and to admit it yourself, but then keep on asking the patient like what they wanted to do. You know, does this treatment seem like an option, or you know, what they felt comfortable doing.
Okay. How comfortable did you feel with knowing what those next steps would be in either of these cases? Did you feel prepared? Did you feel lost?
I felt like I was prepared, but only because I worked in the ER with like the most psych and drug related admissions in Missouri. I feel like since we really haven't touched on mental health, you know, diagnosis and treatment yet, at least in DO school for first years, that's probably the only reason why I knew what sort of like the next steps would be.
Okay.
Yeah, I think that Sarah's presentation with Lisa was very informative back in October for the DO students, you know, just kind of breaking down alcohol use disorder and PTSD and kind of what those steps look like. and then being able to provide options to your patient. And so, like, because of that presentation, I felt comfortable and confident, discussing those with the patient.
Okay. How was the communication between, so we know that it's a little bit awkward to have the patient in the box on the screen. How did you navigate the communication between yourself and the other health professional, between the student doctor and the student nurse? Did it go well? Did you stumble? Any surprises?
I think it went pretty good.
Yeah.
Yeah.
Okay.
And also, like, having the patient there for it, I think that was fine, because that's also kind of how it is, like, when you give report. I don't know how it is from nurse to doctor, but like nurse to nurse, you do it at the bedside and the patient's right there. So I didn't think that was bad at all.
Okay.
Yeah, I mean, from the doctor's side point, I thought it was the same way.
Okay.
I mean, Ellen was actually the nurse with me on that case. I think it went fine. I think the only thing that I struggled with was like with the nurse there, like, I didn't want to, like, I don't know, like, when I was talking, I wanted to make sure I talked to them both. It's, they're obviously all part of the conversation, and through Zoom, that kind of makes it a little bit difficult.
Sure. Yeah. Yeah. Nursing, have you all experienced, you have a lot more clinical experience than most of these student doctors do. Have you experienced these types of patients, and anything you want to share from your clinical experiences?
Yeah, so I work at the Missouri Psychiatric Center at Mizzou. I did my student nurse externship this last summer, and I think that what's so important about a lot of patients that come in seeking psychiatric help is they want somebody to listen. And that's kind of hard over Zoom, just because you can't, it feels awkward, because, and Professor Ogden has taught us a lot too. It's important to give moments of silence for the patient to think about what they want to say and respond. And it's kind of awkward over Zoom because it feels like you just don't have anything to say, but it's really just kind of trying to allow them the opportunity to speak. So that makes a huge difference with Zoom too.
Isn't that interesting? So silence on Zoom feels very flat, right? Silence, when you're together, you still have energy that fills the air. Today, I'm in this office alone all the time, but today another person came in late today in the afternoon for one meeting, and she was in an office way over there, but just her presence, she wasn't making noise, but just her presence, you could feel another person. And that's a real difference, isn't it? Yeah. Yeah. And especially for patients, it'd be one thing if you're like, well, I've got this, sore throat, my tonsils swollen, I've got some, some pain when I do this, and I'm, whatever. But when you're talking about these kinds of issues and you really want the person to feel heard, but you need to kind of draw things out of them, it's a little bit different. So a different skill set for sure. What do you wish you had done differently now that you're in this safe zone without the patient? Anybody want to be vulnerable and say something that they wish they would have remembered to do, or would have handled differently, or would have approached differently?
I mean, I know me personally, like, I forgot to get background information, just like not even thinking about it. So if I could go back, I would definitely get more background information.
Okay.
I wish I would have urged the patient to talk more, because I feel like I was struggling to get information out, but all of those therapeutic communication techniques, I just they were just out of my mind. I wish I would have been oh, tell me more, tell me about that, they teach you to, and then I was just they were gone.
Yeah, right. Right, because you get in there and you want to you feel like the clock's ticking and you want to get all the information so you can do the parts you're supposed to do. But really, if you just ask those open-ended questions and let the patient tell you the story, you almost get all the information you needed without having to ask, right? Yeah. Anybody else?
I know for me personally, I have a habit of saying like little words to make sure that someone knows that I'm listening to them. But I will use the words at the time that aren't the best. Like when my patient is asking me about like, I was asking the patient about like her social history, and I was like, or do you smoke tobacco products, or do you use any tobacco products? No. And I was like, okay, cool. And I was like, do you drink? And she's like, yeah, I have about 1 to 2 glasses of wine with dinner every now and then. I was like, oh, okay, cool. And I'm like going down the list saying cool. And under certain circumstances, that could be like not good.
Yeah. Over time, when you have the great opportunity of watching your SP encounters for the DO students, you will have the opportunity to fix some of those things. And it's great to find something. It's always great in every encounter, really in everything we do, to find something that you want to improve, right? And if you just improved one thing every time, think of how quickly we would grow as humans and in whatever our, skill sets are. Yeah.
I know that's why I really appreciate these opportunities for SP encounters, because every time I do it and I get feedback, I'm like, oh man, I forgot to ask about that, but I never forget again. So it's really valuable.
Exactly. Anybody else want to share something they wish had gone differently or they would do differently in the future, or maybe when they have a patient that's, actually in need?
So with it being the first like mental health case, I did the history and then was thinking about like a diagnosis and treatment. And so I was more abrupt, and I probably could have listened more and eased into it more versus, like you have a rolled ankle, this is what's going on, this is what we could do. I kind of accidentally did that same thing with my patient, and mental health is just different. And so it was a good learning opportunity of what I could probably do better next time.
Good.
Yeah, and kind of piggybacking off of that, I struggled a little bit with, I just felt like my questions were kind of all over the place. Obviously, when you have a different kind of presentation, it's easy to follow cop maps with some of the encounters we've done. This is more difficult to follow such a straight, narrow routine of questions to ask. So I did find myself at times kind of floating back and forth on questions and then having to come back. And so that was a little bit of a struggle, a little different than what we're used to doing.
Yeah, so a different approach.
And then going off of what Cody said, I think what I would improve next time is trying to, like with the cop maps, I struggled because a lot of the things, like the person who was the nurse in my room did a great job of like covering a lot. And so then I was questioning, do I like ask a similar question, because was I like truly there? So I think I struggled with, do I cover the same information? Do I try to ask it differently? And so I think cop maps in a way helped, but then was also kind of a hindrance trying to pick in the big picture.
So for some of you, this is probably the first time that you've received like an SBAR report from a nurse. And I'm sure nursing, you've given SBARs a lot of times, but how was that to receive the information, to have to take it in verbally, listen and kind of compartmentalize it all? It's a different skill set than just, reading a chart or doing it all yourself, right?
Yeah, I feel like I was a little bit awkward in the transition, just because mostly when I came in and I was like, hi, I'm student Dr. Casey Halila, and introduced myself and asked how everyone was doing. And I just said, okay, like good, you're doing okay. I just felt like awkward, and I feel like I could practice more on my communication skills with a nurse and a patient at the same time during that situation.
Okay, thank you.
I agree with you, Casey. Like my nurse was great, but and like when she was doing the SBAR, like great, but then I wasn't really sure how I was supposed to respond. Like, am I supposed to say stuff after the SBAR with the nurse and before I transition with the patient? So I felt like I was also awkward with that.
Nursing, do you want to give them some feedback or some tips?
I may be biased, but I still think Casey did great.
Thank you, Chase. You made it easy. Your SBAR was really good. Thank you.
I felt like I was tripping over my words the whole time. I'm like, what all did I include? How did I do it in the right order? Like,
Dr. Trish, I will say my nurse Kaylin was really good. She was very direct at the SBAR. I worked in the ER for a little bit, and so I kind of got to see like the interaction between nurses and doctors a lot, and obviously that similar thing. So I kind of had an idea of how to transition already. But what I felt really made it less awkward was when I went in, I introduced myself to the patient, and then I pretty much asked them, is it okay if I talk to the nurse about what you guys talked about? As a physician, and I said, let me talk to her, and then if there's anything you need to clarify, you can do that, once she has explained everything. And that seemed to kind of be a good transition, because then she could talk, and then after she was done, my patient did clarify something, but then they at least knew that they didn't have to like butt in halfway through, because if the nurse said something that was wrong, or they just want to provide more clarification, they knew that I would allow them the opportunity to do that. Yeah.
Super. That also shows a partnership between the healthcare professionals and a real respectful, kind of alliance, like you're both there to help the patient and you're doing it together, and you want to make sure that, you've got all the information. And so that's a great way to approach it, I think. What else do you want to tell me? What am I missing? Sarah, what do you want to make sure that they take home? Anything?
It sounds like they did a really great job. I think one thing that came to my mind that Cody identified with kind of a transition, and like when you gain information from a nurse, I think it's good sometimes to say like, I hear you say, or the nurse identified this, and kind of replaying it. Then the patient has the opportunity to jump in and say yes, but you missed out this, and give you more information. I think it sounds like you guys did a good job, and I know that being your first cases with mental health, I'm sure it was awkward, and a lot of you, none of you have had psychiatry yet. So just all the great things there are to come. Of course, I'm a little biased. It's my preference, mental health, but you'll get a lot of great education and exposure clinically. So, and I just really thank you all for doing this. It's great. It's so exciting to Lisa and I. We get very excited about these things.
Yeah, and what a great turnout. And just to reiterate what Sarah just said, especially in these mental health type cases, when you validate and give them back their words, you restate, they realize that that's normed. Okay, so now that's okay, and that may actually enable them to then dive deeper. So the fact that you've just repeated, this is what I've heard, kind of puts it out there, and now we're all okay with that, and we can go farther. And so that's a really, it's a great technique in any clinical situation, but especially with these kinds of situations. Well, I am excited to see so many of you and taking time out of what is, of course, an extraordinarily busy time for all of you. And great to have medical and nursing students together. Always the best. And we don't get to do it far, near as much as we'd love to. So you guys are the lucky ones to take advantage of it. We'll hope to get you all together in the HPS lab, maybe late next semester, if we're lucky. So thank you. Thanks for doing this. Any closing comments from Dr. Ogden or Lisa?
I just want to say definitely thank you to the nursing students for joining us. I feel like, Truman's my alma mater, and so I'm a little partial to your program. But I know that I couldn't be more thankful to have students in my backyard that I could put with my med students, and that we can work together so well. And so I look for future opportunities for this like this, and then maybe other opportunities where we can come into the Performance Assessment Center together, the HPS lab together. I mean, I don't know when that's going to happen. I wish everybody would just be well, and then maybe we could. But thank you for your patience. I know we had some technology problems in there too. Katie and Heidi, thank you for not jumping, all over me for that. Sometimes just, I think the thing that I said was, this is like a telehealth scenario, and in the real world, telehealth scenarios will have technology problems. And so unfortunately, you all got to experience a little bit of that tonight too. So thank you for your patience and understanding with that. I really do appreciate it. And I look forward to another time with y'all in the future. I think we can go back now.
Well, be safe. Thank you. You're awesome.
Thank you for your time.
Thank you for offering.
Thank you.
Thank you all.
Thank you so much.
Bye, everybody.
Bye. Thanks.